Hi, everyone. Can you all see my screen okay? Okay. Well, thanks so much for having me today. Thanks for the introduction, Mike. I'm impressed you got the name correct. It's kind of a mouthful, but my name's Holly Estes Doetsch. I'm faculty at Ohio State University in both medical dietetics divisions and health sciences divisions. I'm also Lend faculty at the Nysonger Center, and then also I do have an appointment in gastroenterology as well. So I mainly manage patients with micronutrient deficiencies, and then also help patients who are on nutrition support at home. So they might be on a tube feeding and not being, able to meet their nutritional needs by mouth. Before that, I spent a few years at a pediatric hospital working inpatient with kids with a lot of different chronic diseases. So my presentation today is disorders that impact nutrition. So yes, you got it right the first time. And these are my key objectives. There's a lot of disorders that can impact nutrition. So I'm going to be basically describing 3 different conditions that can influence nutrition status and can also be observed more frequently in children with neurodevelopmental disabilities, along with their common signs, symptoms, and management approaches. So first of all, just to kind of look at this on more of a broader scale, there can be a lot of different etiologies by which nutrition status can be influenced. So for example, inadequate dietary intake, the person's just not able to eat enough calories, enough protein to meet their nutritional needs. They may not be consuming enough vitamins or minerals, also known as micronutrients, to meet those needs. Also too, the person could be eating fine, but have altered nutrient utilization, which just means that nutrients are metabolized a little bit differently in their body, just depending on the underlying disorder. We can also see impaired nutrient absorption, and this often involves diseases of the gastrointestinal tract, but sometimes it involves accessory organs too, such as the pancreas and the liver, which secrete substances into the intestine, and those impact our ability to break down those nutrients and absorb them. Okay, so when we think about nutrition outcomes, primarily in pediatrics, we're focused on adequacy of growth and development. And we know that there's different disorders that can impact linear growth, impact rate of weight gain, impact even cognitive development. And this could be through inadequate consumption of energy, protein, but also too, if micronutrients are underconsumed, that can lead to a lot of different symptoms. It can lead to health issues the longer that it persists. And those micronutrients can also, or the lack thereof, can negatively impact growth and development as well. So if we consider nutrients such as iron deficiency or like vitamin D deficiency, zinc, all of those can negatively impact growth and development. So I'm going to start off with celiac disease. This is an immune-mediated disease where the ingestion of gluten, which is a protein in certain types of foods, trigger an immune response. Okay, so the immune response is causing a bunch of inflammation in the small intestine, and that results in damage over time to that intestinal lining. Nutrients start to become malabsorbed, so they're not actually getting into the system and supporting growth and nutrition status. The prevalence is around 1% in the general population, but it's actually higher in some other populations. You can see Down syndrome, Turner syndrome, Williams syndrome have an increased risk for celiac disease. We don't know why, but the numbers are higher in these populations. Some of the other patient populations would be type 1 diabetes and also some thyroid diseases as well. Our screening recommendations, and screening just kind of refers to getting some blood drawn and looking for a certain antibody that's in higher levels in people with celiac disease. If they screen positive for this antibody, then kind of the next step is to undergo an intestinal biopsy to confirm that diagnosis. So it's recommended that if anyone's having symptoms of celiac disease, that they get screened for it. And then also high-risk individuals as well. So high-risk individual would be anybody with a first-degree relative that has celiac disease, and then anyone that is within a population that has a higher prevalence of celiac disease, such as Down syndrome, Turner syndrome, Williams syndrome, type 1 diabetes, et cetera. Okay, so these are kind of some of the classic signs and symptoms that we do see in individuals presenting with celiac disease. First of all, abdominal pain, bloating is very common, diarrhea, consistently after eating meals, or appetite, so not really having the desire to eat, anemia. Anemia can cause fatigue because hemoglobin and hematocrit are lower in the body, and that's affecting the body's ability to transport oxygen to the cells. And then this next one, dermatitis herpetiformis. This is a skin condition. It's basically these bumpy, blistery rash that can be really itchy. It's usually symmetrical, so it's on both sides of the body. It can affect usually the knees, the elbows, the forearms. So there's kind of some specific sites where you tend to see that on the body, but that's specifically associated with celiac disease. And then in pediatric patients, forelinear growth is very common in people with celiac disease at time of diagnosis. And then also it's not uncommon to have had weight loss or just very poor weight gain, where they're not gaining weight at the rate that would be expected based on standard growth charts. The only management that is implemented at this time is a lifelong gluten-free diet. And I'll talk a little bit more about that in a second, but at the time of diagnosis as well, a lot of vitamin and mineral deficiencies are common, particularly iron deficiency, vitamin D deficiency, sometimes vitamin B12. There's usually, several different vitamins and minerals, and it's really important for those deficiencies to be corrected. And so they may be on a supplementation regimen, at least right at the beginning, until their gastrointestinal tract heals. And after a few months of being on the diet, their gastrointestinal tract will begin to heal. They'll be able to absorb nutrients a lot better. They'll be feeling much better after following this diet. A gluten-free diet can be really challenging for people who are first starting to adopt it. Gluten is a protein found in wheat, barley, and rye. And so a lot of times people kind of see that and they're like, okay, well, I'll just avoid those grains. But the tricky thing is gluten is found in a lot of different ingredients. There's a lot of additives in foods, a lot of processed foods, salad dressings, soups, dressings, or sauces, etc. So you can really, see these gluten-containing ingredients on the food list, and that can make it really, really hard for people at the beginning when they're starting to become familiar with what ingredients to avoid. They're needing to search for alternative grains to include. So grains that are not, wheat, barley, or rye, things like corn, potato, rice would be examples. And then they're also needing to take special effort to avoid cross-contamination too, especially if other people in the household are not following the gluten-free diet. If you're using the same, cooking utensils and that type of thing, cross-contamination can happen pretty easily. And then if that person is re-exposed to gluten, those symptoms are going to come back and the person's not going to feel very well. We do tend to see gluten-free diet used in conjunction with a casein-free diet, commonly in kids with autism spectrum disorder. And I don't know if anyone has encountered this. It's not currently recommended at this time as an adjunct therapy for ASD, But there's kind of this theory floating around that gluten and casein, which is a protein found in milk, are not broken down appropriately in people with ASD. And so those those peptides kind of leak through the GI tract and travel to the brain and kind of cause changes in the brain, and that can impact function, psychosocial functioning in people with ASD. It has not been supported, but I do know many parents who have tried it. They're just looking for some alternatives. I think first and foremost, though, it's really important that if somebody does decide to give this a try, that they be educated on how to best meet the child's nutritional needs on this diet. Just because, again, it's not easy. There's also a lot of added stress to it. We haven't unfortunately seen the efficacy in clinical trials. So the second thing I want to cover is constipation. I think that this is pretty widespread in a lot of different pediatric populations. There is organic constipation as well as functional constipation. Organic constipation is only a small percentage of cases, so about 5 to 10%. Most cases are functional constipation. So the difference is that organic constipation is due to some type of underlying medical condition that's driving that constipation. So for example, if we think of spina bifida or cerebral palsy, those involve the neurological system, and that can impairments in nerves can also lead to impairments in bowel motility. So how the bowel is actually pushing contents of foods throughout the gastrointestinal tract. Functional constipation is when there's really no underlying medical reason for it. And the Rome 4 criteria is used to diagnose functional constipation in children. And so I have that criteria presented up here. But a lot of the causes that have been associated with this functional constipation include dietary inadequacy, particularly dietary fiber, and then also fluid. So those tend to be the major dietary factors that are impacting bowel motility. And then some behavioral factors as well. If there's anxiety around toileting, or the person is withholding for some reason, that would be behavioral factors. And then some medications are also associated with a higher risk for constipation. And actually something I don't have on here too is that high emotional stress and anxiety has been associated with constipation as well as decreased physical activity. So kind of more of that sedentary behavior, people who are more immobile. Some of the signs and symptoms kind of correspond back to that Rome 4 criteria. So small, dry, hard, sometimes painful bowel movements, so hard stools, stool withholding behavior. Sometimes people will report urinary incontinence, so the urine will start to leak because a lot of stool has kind of built up in the GI tract, and that's pushing against the bladder. People who have a really high stool burden, a lot of times just they don't feel good. They're having some abdominal pain. They have a decreased appetite. They may experience some weight loss from that. So our key management for this involves laxative treatment, generally, at least as a starting point. That might decrease, over time, just depending on how the child responds to that. But in conjunction to finding strategies to increase dietary fiber intake, increase fluid intake as well, and then behavioral approaches around toileting can be utilized. Excessive milk intake has also been associated with constipation, and sometimes reducing that milk intake can actually help ease constipation. And excessive milk intake, we're kind of talking, 5-6 cups of milk per day, well beyond the guidelines of 2 to 3 cups a day that would meet the calcium needs of a lot of younger children. And then the final disorder that I wanted to present that you might find kind of interesting is avoidant restrictive food intake disorder. It's also known as ARFID. It was more recently added to the DSM-5 when that was published in 2013. And this is defined as an eating disturbance leading to persistent inability to meet nutritional needs associated with at least one of the following that's listed below. So either significant weight loss or inadequate growth, nutritional deficiency, dependence on tube feeding or oral nutrition drinks, and interference with psychosocial functioning. And sometimes people kind of glance at this and they're like, oh, this actually seems similar maybe to anorexia nervosa. But with ARFID, there's no body weight or shape concerns present. The other thing too that tends to be associated with these eating disturbances would be either a fear of eating, and that could be driven by some type of traumatic experience involving food, such as a choking incident, or if the person has had prolonged gastrointestinal symptoms and maybe it took a while for the condition to be diagnosed finally, and the person's kind of scared to eat again just because they're fearful of re-experiencing those GI symptoms. Another possible cause would be sensory disorders as well, having really high sensitivities to things like the texture, for example, of foods. And we know that in ASD, there's been a lot of literature on a high prevalence of food selectivity. A lot of people call this kind of your picky eating, except that in ASD, it's not transient. We might see in other populations. This is usually a very rigid behavior. And oftentimes we'll see eating patterns where the person is choosing foods based on the texture, based on the color or shape of the food, even smell or temperature, brand. It's very, very restrictive. And so sometimes we'll kind of see this very limited food repertoire in some of these individuals. That doesn't always mean they're going to develop ARFID, but it does increase the risk for ARFID. They may have kind of this excessive intake of certain types of foods while restricting other types of foods. They might frequently refuse foods. And there might be a great deal of distress sometimes around foods that are non-preferred food items. So just some of the things that sometimes we'll see in individuals with ASD. All right, so our signs and symptoms, very limited food repertoire, especially if you notice it becoming more narrow over time, more limited. A lack of interest in eating, not seeming to have much of an appetite, poor growth, poor weight gain or weight loss, and then physical findings and symptoms consistent with nutritional deficiency. For example, fatigue and pallor are common with nutritional anemias, such as an iron deficiency or B12 deficiency. Hair loss as well can indicate nutritional deficiency. Muscle loss, not getting enough energy and protein in the diet. And muscle loss too can decrease muscle strength, muscle function, start to lead to fatigue as well. Our management there's not a lot of evidence-based management around ARFID, but I think there's kind of this consistent thought that an interdisciplinary team can be very effective, just because there can be medical complications from this. There's concerns with meeting nutritional needs, and then there might need to be a number of behavioral strategies as well that are implemented. And so really the management involves correcting any nutritional deficiencies, weight restoration, if they've lost a lot of weight. Some people do require some oral nutrition supplements, at least at the beginning, until they've been able to expand their diet, or tube feeding even, and that's kind of more severe cases. Cognitive behavioral therapy and or feeding therapy may be utilized. Feeding therapy involving an occupational therapist, speech therapist can be really helpful for kids who are having those sensory disorders, and supporting children with that gradual exposure to different types of foods so that they can expand their diet. Cognitive behavioral therapy can be really helpful for people who are dealing with a lot of that anxiety, those food fears. Here are some references. And hopefully that was around 15 minutes. That's what I was aiming for. So